This is Cesar Migliorati from Florida, University of Florida. I am videotaping this brief presentation to be part of this meeting that is being organized by Vittorio Fusco and Giuseppina Campisi, my dear friends from Italy. This is going to be a short presentation, just so you know, it's mostly an overview of what happened in my career when I came about the discovery of this condition. So the title that was given to me was ONJ, Bronze, an American Tale. What I wanted to cover today briefly is the process of discovery of this condition, what is the American consensus until today, and some aspects of diagnosis and management. It all started for me in the early 2000s when I was still in Brazil working in the cancer center in São Paulo, when referrals came to our clinic of patients who had exposed necrotic bone. My colleagues had tried to treat, but there was no response. And these were patients with breast cancer initially. Then after seeing a few patients in Brazil, I came to live in the United States. And the first cases that referred to me in the oral medicine clinic were patients who had the similar conditions like I had seen in Brazil. Patients with cancer, usually metastatic to bone, who had areas of osteonecrosis, visible necrotic bone in the oral cavity. So when I saw this, I said there must be something going on because it's similar to what was happening in Brazil. And I thought, well, there was clinically exposed necrotic bone. It was similar to cases of osteoradionecrosis, but no history of radiation therapy in the patient's history. Patients that were involved, some of them had cases similar to what I was observing in severely immune suppressed HIV patients who had periodontal bone necrosis, and also patients who had metastatic breast and prostate cancer and multiple myeloma. So the initial observation was that no matter what we did for these individuals using standard management procedures, there was no response to therapy. And the common factor observed in all patients is that all of them were taking the bisphosphonates. So I went into learning about the bisphosphonates, and I found out what the mechanism of action was, and I felt that they could be, being the only common factor amongst all patients, could be one reason why the patients were developing this condition. So I asked myself, what do I do next? I didn't have much support, was working on by myself. And so I decided, am I going to report to the manufacturer of the drugs? Should I report to the Food and Drug Administration, or should I publish? My decision was that I wanted to publish and let my colleagues, both physicians and dentists, to know that these individuals were developing this process. At the same time, other colleagues in the United States reported similar cases, and after that, a lot of other publications came about, and the companies manufacturing the bisphosphonates got involved in the process. There were reports coming all over the world, and Novartis Merck contacted the authors of reports and started to ask for the case reports. They want to know what we were seeing. That's when the letter, Dear Doctor, a letter was sent to 150,000 dentists in 2005 by Novartis, and later on another letter, but now not just to dentists, but oncologists and neurologists. There were hundreds of publications reporting cases all over the world, And that's when management guidelines started to appear by the American Academy of Oral Medicine, the American Association of Oral and Maxillofacial Surgeons, and the American Society of Bone and Mineral Research. There was a conference call of our group from MASC, ISOO, and Novartis. The idea was to propose that we could do a study together, but Novartis was resisting the idea, saying that they had done studies, clinical trials involving thousands of patients, and that they had not seen this problem. But with our insistence, they went back and did a retrospective evaluation of their breast cancer clinical trials, and they ended up finding that they had missed several cases because oral cavity was never part of the protocol of examination of these patients. So with that in mind, we started to discuss amongst our colleagues what to do, what is the best way to diagnose, what is the best way to prevent, and what's the best way to manage. That's when the surgeons got together and put together guidelines, and the most current and that is still valid today is the one that was updated in 2014. And the way we define this condition is that it's a patient who has current or previous treatment of anti-resorptive or antiogenic agents that comes in the clinic with visible exposed bone or bone that can be probed through an intraoral or extraoral probe or fistula, and that there is no history of radiation therapy to the jaws or obvious metastatic disease. So you have a patient with exposed bone. This is an early case that we can stage as stage 1 when you just have an exposure of bone that is necrotic, but no symptoms. Patients who now have symptoms and delayed healing after extractions, like this patient who had osteoporosis and was taking ibandronate for many years. In more advanced cases or stage 3, when the lesions are advanced, there is extraoral fistula and the risk for necrosis. So, in addition to these cases, the reports of non-exposed osteonecrosis, and there is a controversy here between several groups, including the Americans, because of the definition. So we know that you can miss cases of osteonecrosis because you don't see the exposed bone, but in reality, they are there present. So in a quick summary where we are today, we have thousands of papers published in the literature. There are a number of acronyms galore, but the one that has been accepted by most is ONJ. Cases have been reported worldwide, and there are some questions that are still not completely answered. So what is the exact mechanism that leads to ONJ? What is the most effective prevention protocol for the treatment? And there are reports now of new drugs, including non-associated bisphosphonates or denosumab, pardon me, that are being reported by colleagues. So there are several drugs now associated, the most traditional and some new biologicals that are causing similar problem, but in patients not using bisphosphonates or denosumab. These are cases from my colleague from the University of Texas in Houston, MD Anderson. Patients with severe cases of osteonecrosis. Questions that I'm asked the most by my colleagues because of the early reporting of cases is, can we treat these patients? And the answer is that the number of patients who are involved in this condition is very small from preventing them to receive routine dental care. This is a case that was done in our student clinic, a patient who had a long history of taking medications, I think it was alendronate, and the patient had full mouth extractions and then dentures made and no cases of osteonecrosis. So management of early cases can be done by just following the patients, depending on the stages. In the early stages, mostly stages 0 to 2, according to the American guidelines. This is a breast cancer patient who I followed for several years. And because of her medical condition, we were not allowed to do any surgery. And she ended up exfoliating the tooth in the area of osteonecrosis and healing completely just by doing follow-up and periodic treatment with antibiotics and so on. Nowadays, people are using combination of pentoxifylline and vitamin E, a process that may take a long time to show clinical results, but is also an alternative. And the most current opinion by colleagues is that you can do surgery directly and obtain a very good result. So it was a brief presentation just to get the stage started for this meeting. Next, you're going to hear the opinion from other colleagues about the different ways to manage these conditions depending on the philosophies that you follow around the world, and also that the consensus about Italy, how the Italians are managing these cases. So I thank you very much. It's been a pleasure, and you can always contact me, and either by phone or by my email. I'll be happy to correspond with all of you. Thank you so much.